Hello, everyone. I'm Dr. Angela Mattke, and you are watching Ask the Mayo Mom, a Mayo Clinic's Facebook Live. I'm a pediatrician at Mayo Clinic Children's Center, and twice per month I host a show about pediatric health topics where we take and answer your questions live. Today we will be discussing epilepsy in children. Joining us for this discussion are two experts in this area. The first is Dr. Anthony Fine, a pediatric neurologist and epileptologist, as well as an assistant professor of neurology. The second is Dr. Kai Miller, a pediatric neurosurgeon with special expertise in surgical options for the treatment of intractable epilepsy in children. Dr. Miller is also an assistant professor of biomedical engineering and pediatrics. It's going to be a great discussion today. So please send your questions under the Facebook Live video feed, and we will try our best to review them during the live broadcast today. So Dr. Miller and Dr. Fine, thank you so much for joining us here today.
Thank you for having us.
Thank you.
So let's start by talking about and defining what actually are seizures, because that word sometimes can be really frightening and really scary, but it can look like a lot of different things.
Yeah, and so technically a seizure is an abnormal electrical discharge or extra electrical activity that kind of disrupts the normal brain function. And what you see in a seizure can be really different depending on where in the brain that electrical activity is coming from.
And how common are seizures in the general population? I think there are some types that seem a little bit more common, like febrile seizures, but how often should we expect to maybe see them?
So seizures are actually really common.
Okay.
You may not always hear that someone had a seizure, but if you kind of ask around, you'll hear more frequently, oh yeah, I know someone who had a seizure, I had a seizure. In children, we estimate that about 1% of children will have a seizure by the time they're kind of teens.
Okay.
And so that's 1 out of 100. That's a lot. When in terms of more common seizures, yes, febrile seizures are more common seizures. Probably seen in about 3 to 5% of children.
Okay.
And those are seizures that we see in the setting of fever and illness. And it gets kind of further complicated because we kind of like to subclassify things, and so there's what are called complex febrile seizures versus simple febrile seizures. But broadly speaking, seizures in the setting of fever. What makes them more complex if you have kind of back-to-back febrile seizures in a 24-hour period, or they have what we call focal features. So only part of the body is affected, or we think that it starts in one brain area before spreading.
Interesting. So there's other different ways that you classify seizures based on kind of what part of the brain it's occurring. Can you explain some of those as well?
Yeah. And so probably one of the simplest ways that we break down seizures is, do we think this is generalized, or is it focal, or do we not know? And so generalized just means that the extra electricity is happening all over the brain at one time.
Okay.
Whereas focal, it starts in one spot and it may stay in one spot, but sometimes it could also spread to generalized. Then we try to break it down by what types of seizures are we seeing. And so how people call seizures or name seizures can vary depending on who you ask or what you look up.
And it's changed a lot over the years, I feel like. Things that I used to be terms are no longer used anymore. So.
Absolutely. And so every few years our classification of seizures and epilepsies changes.
Why does that keep happening?
And the goal is to improve kind of communication between everyone. Doctors, patients, families, other providers. But it does tend to lend to the confusion if we change the names every few years. The most recent classification was in 2017. Before that was kind of 2010. And we've had kind of different variations since. So one of the more common types of seizures in children are something that we call absent seizures. These used to be called petit mal seizures, and you may still hear that referred to as petit mal seizures. And these are kind of zoning out episodes. Kind of children just kind of freeze, stare blankly. Sometimes their eyelids may flutter or eyes may look up. You may see some kind of mouth movements. And then they kind of go back to what they were doing. You could see these really frequently. And so that would be called absence epilepsy. Sometimes it's really hard because children daydream and stare, and so it's hard to kind of figure out, is it a seizure or not? And so that's when our other studies become very helpful. Okay.
So you mentioned the word epilepsy. So does having a seizure mean that you now have the diagnosis of epilepsy, or how does that occur?
So that's a great question. So a seizure refers to kind of a single event. once you have kind of 2 or more seizures that aren't what we call provoked, so there's not something causing the seizures, such as fever or head injury, illness, an infection, then that's epilepsy. And so it's kind of a very fine line between having seizures and having epilepsy. And really there's some people prefer not to refer to it as epilepsy. They like to say it's a seizure disorder, but really we're talking about epilepsy. And it is important for treatment and just kind of communicating to families and other providers that yes, this child has epilepsy.
Yeah, absolutely. Because people seem to understand what that means, that there is a risk for future seizures in the future that probably, in most cases, would need some type of treatment or monitoring at the very least, right?
Right.
Okay. So one thing that I think a lot of parents are concerned about is, febrile seizures, because they are common. Does that mean their child is going to go on to develop epilepsy?
So that's another good question. So febrile seizures do increase the risk of developing epilepsy slightly. Okay. So it's what we would consider an epilepsy risk factor. So the majority of children who have febrile seizures don't develop epilepsy. And so if the risk of epilepsy is about 1%, having febrile seizures raises that to about 2 to 3%. If they're more complex febrile, kind of 3 to 5%. Okay. And then there's other factors that we take into account, such as family history, and then just the child's history. So if they have any medical complications like prematurity or developmental delay, each of those kind of independently increases the risk for epilepsy.
Okay.
And when you say more complex features, what do you mean by that?
So yeah, absolutely. So with febrile seizures, just more complex means if prolonged febrile seizures, usually greater than 10 to 15 minutes, kind of back-to-back febrile seizures, or kind of those focal febrile seizures. And so those kind of increase the risk for epilepsy compared to very short, generalized febrile seizures.
Okay. So focal meaning it involves one particular part of the body.
Exactly.
Yeah.
Okay. So what about in non-febrile seizures? We're talking about what are some other risk factors for the development of epilepsy? I imagine they're kind of similar to what we've just talked about. But,
they are pretty similar. So kind of starting early on in life. So if you're born premature, and kind of the risk is higher if you're kind of earlier. So the earlier you're born, the higher your risk compared to kind of if you're born closer to term. And then when we think about complications when you're born premature, and so bleeding in the brain, or kind of meningitis or an infection around the brain or spinal cord, and then developmental delay also increases your risk. A serious head injury will increase your risk. And usually that's associated with some sort of injury to the brain, whether it's what we call a bruise or a contusion to the brain, or any bleeding on the surface of the brain or within the brain.
Some of the situations that you would be a part of taking care of, right?
Yeah, and so from a neurosurgical perspective, we really, well, obviously, I don't really do anything other than with the neurologist, which is not the case today. But we think about basically dividing epilepsy up structurally. So when we look on the MRI, is there something we can identify that we look at explicitly? And then I have something that we can pursue surgically, versus seizures that may manifest with a particular part of the body, but we don't see anything abnormal on the MRI. And then we look for electrical activity to clue us in on the underlying cause for the seizure.
So you're getting into some of the things that would be involved with the evaluation of epilepsy. So if a child is coming with multiple seizures, and they're most likely presenting in your office first, but I know there's a lot of collaboration between you two. Why don't you guys tell us about what some of that evaluation would look like?
So usually first stop is kind of the pediatric neurology clinic. And if we're concerned for seizures, we may get what's called an EEG, or electroencephalogram first, which is a brainwave study. Okay. And so electrodes are kind of placed on the scalp in an organized fashion, and we measure kind of brainwave activity. And we're looking for just kind of baseline, what's the brain doing at rest? And then we try other maneuvers to try to see if we can kind of bring out other activity. And so we're looking for that extra electrical activity to kind of give us clues. Whenever we see a child who's having seizures, the biggest question is, what's the cause? And then that kind of leads us down to kind of our surgical interventions. And so kind of we're always thinking, is this someone who we treat with medications alone, or is this someone who could potentially be a surgical candidate down the road? And so after that, the initial consultation, then we may do some other studies. So brain imaging, like an MRI, to look kind of closer at the structure of the brain. And then we might do longer EEG monitoring to try to really localize where the seizure's coming from.
Okay.
And my involvement will generally come at a couple of different points initially. The first would be Dr. Fine or one of his colleagues sees a patient and says, you know, we have some overlap in our clinics. Can you see the patient today or come over? And then we'll discuss things sort of generally initially, so I can meet the families, and whether or not surgery ultimately becomes an option that's going to help the child. We've established a relationship where basically I can educate families. The other step at which I'll become involved is Dr. Fine, one of his colleagues, will initially see a patient. We'll get brain imaging and EEG, and then discuss the patient in our multidisciplinary conference, which we have twice weekly. And at that conference, you have neurosurgeons, so myself as well as the adult epileptologists, the adult epilepsy neurosurgeons, the adult and pediatric epileptologists, and also the neuroradiologists. And we sit in a big conference and discuss patients on a case-by-case basis, and then if it seems like surgery or surgery is potentially going to be part of the set of therapies that will be an option for families, then the committee as a whole will decide to refer the patient to my clinic.
Okay.
And so that's a great point. All of our surgical decisions here at Mayo and at many other centers are kind of consensus based, and so it's not any one provider saying this is what should be done.
Right.
And so it's kind of a group decision and kind of what are the best recommendations to help the patient. And I think that's really important because everyone has different opinions, and it's important to get everyone's opinion. And so that's kind of the benefit of having all these resources.
Yeah.
And getting the input from not only our pediatric epilepsy doctors and pediatric neurosurgeons, but also our adult colleagues too, because they may see things differently.
Yeah, there's a huge wealth of knowledge here that you guys can pull from, which is fantastic.
And pulling from that is not, it's done systematically. So we have the committee meeting and discuss every patient. It's not we sort of discuss things ad hoc and say, well, does this patient need committee or not? It's systematic for each patient.
Yeah.
Okay.
And then when I meet with the patients and their families, I'll tell them this is the set of therapies. The committee consensus was one particular thing or another, and I think we're going to get into that a little bit later. But I'll also say, you know, there wasn't, as a team, you know, sometimes we do think there are options, and then depending upon how definitive we want to be, and how definitive we are in the treatment of epilepsy is also correlated with how invasive we are. We'll present that to families, and then it's a choice that's made over time. It's not that the first time you see me, I'm going to tell you, hey, this is, you know, your child needs surgery, or your child needs the most invasive or least invasive thing. That's really a spectrum, and the spectrum that I present to families, or at least attempt to, is meant to reflect the committee as a whole.
That's fantastic.
Yeah.
So when a family comes to you with an initial diagnosis of epilepsy, would they automatically go to the committee first, or would you start other treatments, and what would those treatments be?
So usually before we start to think about kind of surgery, it really depends on the cause. And so we start thinking about epilepsy surgery when there's definitely a clear structural cause and we're having trouble controlling seizures with medication alone. And so we usually say you have what's called intractable epilepsy or refractory epilepsy if you failed 2 or more medications at good dosages. And so then, you know, we're starting a second medication, we have a known cause for seizures, or we have a hypothesis that seizures are coming from one location, then we start to think, is this patient a surgical candidate? And we try to think about that early. So sometimes even at the first visit, I may kind of bring up, in the future, if we have trouble getting control of seizures on medicine, there are some surgical therapies that we can consider. And the reason being is that sometimes earlier surgery helps not only control seizures, but other aspects of life, such as development and cognition. And so that's why we try to think early about surgery.
How often will children fail medical management, meaning just medications alone, and need to start thinking about other options?
And so it really depends on
the type of epilepsy, right?
Epilepsy.
Yeah. And we didn't get into the different types yet, but
yeah. And so for children with a structural cause of epilepsy, sometimes we get very good seizure control, but some children we just can't control with medications alone, and we could be on multiple medications.
And so by structural cause, you mean?
And so it can vary. And so sometimes it's what we call a low-grade tumor. And so a benign kind of tumor or mass in the brain that can really cause seizures. And so sometimes if we can identify that, that's where the seizures are coming from, then that's kind of definitive therapy. There are other changes to the brain that can happen really early on. So as the brain's developing before a baby's even born, and can result in increased risk for seizures. And so there's lots of different kinds of changes in the brain that can happen. And so some of these are more likely to produce seizures than others. The other thing is kind of the unpredictable nature of epilepsy.
Yeah.
And so it
doesn't follow rules sometimes, does it?
No, it never does. And so you really never know when seizures can start and how a child's epilepsy will respond to medication. And so it's a lot of trial and error.
Okay. We have a great audience question that came in from a family who has a son who has some prolonged seizures, it sounds like, and has failed some medications and hasn't been a candidate for it. So say we don't want to give specific medical advice, but the evaluation then would kind of look into other options at this point. So some of the surgical things. Dr. Miller, can you talk a little bit about that?
Sure. So, I mean, what we look for in general when we're assessing surgical viability, so whether a child would benefit from surgery, is we have three things to go on. We have first the behavior of their seizures. So different seizures have what we call different semiologies, but these are essentially the symptoms that a patient will have while they're having a seizure. So it could be abnormal movements, it could be a prodrome that they have particular smells that they have, it could be a feeling of rising in their stomach, like when you're at the top of a roller coaster, and these point to different regions where the seizures might start. The second is imaging. So we look at the MRI, and not all MRIs are created equal. We have a number of unique resources here to evaluate for abnormalities of brain structure on imaging. And the 7 Tesla imaging that we're able to get here at Mayo is unique. It's and that can show us abnormalities either in the form of a lesion, like a low-grade tumor, where we're treating the tumor not to stop it from spreading, but to stop it from causing seizures, or a tumor that we need to treat as a tumor independent of the epilepsy. There can be effects post-infection. There can also be what are called dysplasias, and dysplasia means that an abnormal process occurred during brain development, and we see specific abnormalities that are localized in the brain in different areas. And then we can also see evidence of scarring. So a lot of times when we talk about temporal lobe epilepsy, we see evidence of scarring from structures called the amygdala and hippocampus. And so the combination of the symptoms of the seizure, the semiology, the imaging that we get, and then the third piece that's very important is the electrical measurements that we make from the surface of the head, the brain waves that we measure. And if all three of those agree, we would call that concordance. And then we might go straight to saying, well, there's a lesion that's in the frontal lobe, and it's producing a particular set of symptoms that agree with the frontal lobe on that side, and the electrical activity that's abnormal that we see in EEG. And the EEG can be done during a day, or patients might come and stay multiple days. And if all three of those things agree, we would say, okay, well, we can intervene with one of the different surgical interventions that we do for that particular lesion. Sometimes they don't. So we may not have concordance because we may have electrical activity and symptoms that don't match. We may not have any abnormality on imaging at all, and our electrical activity and our symptoms, our semiology, point to general brain areas. Or we may have frank disagreements where we see an abnormality on one side of the brain, but all the abnormal electrical activity is coming from the other side of the brain. And the initial surgical steps that we can do, and I think we have a nice image for that, are to implant electrodes into the brain. So this is a surgery that's done not to treat seizures, but to understand where they're coming from. And the image that we have here is of something called electrocorticography, but that's where an opening is made in the skull that's several inches in diameter, and we place electrodes down onto the brain surface, and then we have the patients as inpatients and measure the electrical activity over time. And my colleagues in neurology will try to isolate exactly where the seizures are starting. Now, for many patients, electrocorticography has transitioned into something that's actually much better tolerated and much less invasive, so it's less of an open surgery. And the ECOG abbreviation there stands for electrocorticography, but it's moved to something called stereo electroencephalography. So here we have small wires that are inserted through very, very small holes in the skull and the scalp into deep brain structures and surfaces of the brain, what we call the cortex, in different regions. And here there'll be up to 15 of these placed at a time, sometimes on one side of the head, sometimes on both sides of the head. And similarly, the patients are monitored for a period of typically about a week, but sometimes much longer. And we wait for them to have seizures, and then we identify where the seizures are starting from. And the set of options that we have to offer patients will depend upon what this shows. So on this chart here, it really shows what the surgical therapeutic options for epilepsy are, depending upon where we've localized the epilepsy to. And sometimes this will be because we get concordance between seizure symptoms, so the semiology, the electrical activity, not from implant electrodes, but from the scalp surface, and also from imaging. But quite often they'll result from that monitoring period with implanted electrodes. But basically, the thing that we hope for is what we call an isolated focus. Focus is just our word for the part of the brain where the seizures are starting, that has acceptable collateral. Now, when we're talking about the brain, collateral is something that we take very seriously, and we want to minimize the set of damage we're doing to the surrounding brain regions, and also the set of, frankly, brain functions that are lost in the course of doing this. So these might be things like very small aspects of memory, parts of vision. For many patients, the benefit they get to their cognition and development from not having seizures will far outweigh the loss of those functions. Nonetheless, we do everything we can to minimize that. So in the case that we can isolate a focus, and we basically go to that spot of the brain where the seizures are starting, and we either take it out surgically or we ablate it with a laser or with radio frequency.
Let's take a look at that
burning.
slide. I think you have a slide about the radiofrequency ablation.
Yep, so this is the laser ablation, and the image that we're seeing here is for the most common use that it has, and that is mesial temporal lobe epilepsy. So this is the hippocampus and the amygdala. And what we do is we insert a laser fiber into the brain through a very, very small hole in the skull, and advance that into these deep brain structures with the patient in the MRI. And recent technological breakthroughs in the last 10 to 15 years enabled it so we can see the heating up of the brain from the laser. And basically, for our patients, it means that we can try to destroy the regions of seizure onset without having to either move or take out all of that brain that's between the outside of the head and those inner structures. And these patients do well. They go home usually the next day. The efficacy that we get, meaning seizure freedom, is usually about 10% less than doing an open resection of these brain areas. But doing this laser doesn't stop patients from getting open resections later if the laser is not successful. So this is always the initial option that we'll want to have is, can we identify an area that we either ablate with laser, or we take out with surgery. So that's the first and often the best outcome for patients, is if we can identify a single source. In other cases, we have basically seizures that will be very distributed throughout the brain. So we do something called the Corpus callosotomy, which means cutting the primary connection between the two halves of the brain. And this is done in an open fashion, meaning with an open surgery. But now we're also doing this with lasers. And in this example, that would be these red lines that you see. And this is particularly indicated for patients that have what we call drop attacks or atonic seizures. So throughout the course of the day, they basically will lose all tone in their body and they just spontaneously drop. And this can be catastrophic for their quality of life and for their ability to lead a normal day-to-day existence.
And corpus callosotomy is a therapy that we sometimes recommend for other types of generalized seizures. And so if a child has very difficult to control what are called generalized tonic-clonic seizures, then sometimes we may recommend callosotomy. Another type of seizure is called tonic seizures, and that's usually you kind of have this tonic stiffening up, and this can happen multiple times a day or many times overnight, and corpus callosotomy could also be effective for those seizures as well.
Okay. And we have a couple other options that we were going to share today. Can you go into some of those?
Yeah, absolutely. Would it be possible to go back to that initial slide briefly, showing our decision tree? Would we be able to select that previous slide that had the text boxes? Thank you. So in that top row, you see the different options, right? So we break down the localization of the seizures to what I spoke about before, which is where you have an isolated focus that can come out. Sometimes the isolated focus is in a part of the brain that there's simply no way to ablate or resect because the functional loss would be too great. So this is the inability to move. This is the inability to speak. And so what we do for those patients is we can introduce stimulation devices. We'll use many of these stimulation devices for what we call two foci, or two regions where they're starting. And we have some pictures for that. And then the last indication is what we call generalized or multifocal. So there are more than two regions where the seizures are starting, or they're starting in the whole brain at once. And for this, we do disconnection surgeries like the corpus callosotomy that we spoke about, or even hemispherectomies for some children, which is disconnecting one half of their brain. And for those patients, they've usually had such injury that that half of the brain isn't functioning anyhow. And the third is a generalized stimulation, so vagal nerve stimulation or deep brain stimulation. So one thing that's emerged in recent years is what we call responsive neurostimulation. So the device that you see here is the NeuroPace device. And this device implants wires into targeted regions where seizures are starting. So if seizures are starting, for example, in both temporal lobes at once, we may stick electrodes into both temporal lobes. You can't take out those mesial temporal structures from both sides, so we're forced to stimulate in response. And this can reduce the severity and the frequency of seizures that the child is experiencing. If we could go to the next slide. For children that are having generalized epilepsy, where there's really no surgical target inside of the head, we deliver something called vagal nerve stimulation. And this is a surgery that's performed completely outside of the head. But the vagus nerve is a nerve that's responsible for a large, vagus means wanderer, so it wanders around and influences a large number of things, including your voice, your heart rate, the feeling that you get of nausea that induces vomiting and so forth. And it has a general effect on the brain. So we put this electrode on the vagus nerve in the neck, and then we connect it to a pulse generator in the chest. And what we tell patients is that for about half of patients, they'll get a 50% reduction in seizures or more. So this is a great therapy that I think of as adding another drug on, but it's an electrical drug. And has a general effect for patients where we can't localize their seizures. Yeah.
That's fascinating. And there's one more, the modern DBS. Can you
Yeah,
talk
so
about that as well?
in recent years, we've begun to use deep brain stimulation, where we target structures in the middle of the brain, and this similarly targets areas where circuits distributed throughout the brain, where they converge in an area in the middle of the brain called the thalamus, and we stimulate the thalamus to change the behavior of the epileptic circuit as a whole. So this is where seizures are starting in many places at once, and this changes the general electrical state of the circuits in the brain. And this is really an option more for older children, just because their skull is more developed. And the technologies for doing this have come a long way in just a few years. And so as these technologies emerge and evolve, we'll be offering this to our pediatric patients more and more.
Excellent. In regards to the other ones that you talked about, are we offering these options, these surgical options in treatment management here?
Everything we've
Yes.
shown,
Okay.
we offer. Yeah.
Okay.
So-
And when would families need to seek out another opinion about to their child's epilepsy management? What advice would you offer to them?
And so many times we try to work with a patient's local neurologist and trying to kind of care for the patient. But reasons to go to like an epilepsy center like here at Mayo would be if your child is young, so less than 2 years, and having difficult to treat seizures, if your child's failed multiple seizure medicines, if there's a kind of structural cause in the brain causing the seizures, or if we're thinking about needing a special diet to control seizures, like the ketogenic diet. And it's reasons to kind of seek out a referral to an epilepsy center.
And that would answer, we had some great audience questions coming about children who've been struggling with their epilepsy management. So that may be something for them to consider or to talk to their local neurologist about.
Absolutely.
Seeking out a second opinion.
Yeah,
So.
and we're always happy to see patients for
Yeah.
a second or third or fourth opinion, just to try to help kind of figure out what's the best way to help with epilepsy.
Yeah.
Yeah, and I view my role when I see patients, either for second opinion or primary opinion, it's not that when patients and their families see me that they're going to, that I'm going to say you need surgery. It's more, I want to let them know what the general set of options are, what they can expect throughout the process, and I think that that can be very educational up front, early on. So coming to see a neurosurgeon here at Mayo for your epilepsy doesn't mean that you're going to be told that you need surgery.
Right.
It's actually, you'll be told the full set of indications that you might have in the future that your child may benefit from.
Absolutely. We are at the end of our time,
Okay.
but I want to end with, what resources would you recommend to families, or words of advice you would give them with a new diagnosis of epilepsy?
So I think advice is kind of, there's a lot of scary information out there on the internet, and so kind of be careful of the resources that you're looking at. I think family support groups are very important. The Epilepsy Foundation is a great resource for many families, and many states have very active chapters of the Epilepsy Foundation, and they work closely with families and providers to get the right information out there. Other resources, if you look up most academic medical centers' websites for pediatric epilepsy, they should have some information on what seizures are and what different types of seizures are and therapies. Another resource is something called the Danny Did Foundation, and we didn't get to talk about the topic of SUDEP today, but that does weigh on many families' minds. And so this is a good resource to get more information about the scary, rare complication of epilepsy called SUDEP, and also kind of what devices are out there to help monitor children for seizures.
Excellent. Dr. Miller, what would you end with?
Just that, it's at Mayo we have a really unique ecosystem that I'm privileged to be a part of, where I get to work closely with the neurologists and the radiologists, and in interacting with families, we're really able to tell them sort of the full gamut of interventions that might help them, and we're able to provide those. And so I think that I really hope that, I know that surgical intervention can be very intimidating. I know that as a parent myself, I would want only what was absolutely necessary and the least invasive, and that's the perspective that I try to bring to every interaction with families.
I'm sure they very much appreciate all you guys do for them. And thank you for joining us today
Yeah.
and sharing this knowledge.
Yeah.
And thank you everyone who watched and sent in questions. You can catch the next Facebook Live Ask the Mayo Mom on March 26th at 11 a.m. Central Standard Time. We will be talking about minimally invasive heart procedures for children to repair congenital heart disease. Dr. Jason Anderson, a pediatric interventional cardiologist, will be joining us. Thank you, everyone, and have a wonderful day.